Good afternoon, good evening, everyone. My name is David Winterflood from NOMAN is an Island Race to End HPV, and it's my pleasure to welcome you to Men, Cancer and HPV, Increasing Male Participation in HPV Vaccination, which is today's webinar, which will be running for around an hour's time. If we can just kick off with a little bit of housekeeping, please do introduce yourself in the chat, as so many people are. Use that to make comments, share any thoughts. We will have a Q&A following the presentations today. So do share your questions and inputs in the Q&A function. The way today will work, we'll have the presentations from the two speakers, and then we will move on to the Q&A at the end. So keep them coming through, and yeah, it's an interactive session, and we look forward to your input. And as I said, it's going to be recorded and will be available on the Global Action on Men's Health website and YouTube channel. In terms of today's presenters, well, joining me, I'm your chair, David Winterflood, but we have Peter Baker, who's the Director of Global Action on Men's Health, Professor Maria Grandahl, Associate Professor, Director of Education in Nursing and Midwifery Programs from Uppsala University in Sweden. Welcome, Maria. And Tashi Dawa, who's the Program Analyst from the Vaccine Preventable Disease Program for the Ministry of Health, Bhutan. And yes, I've told you too many times who I am already. So at this stage, I'm going to hand over to Peter, who's going to tell you a little bit more about NOMAN and Global Action on Men's Health's work. Peter, I'll hand over to you.
Thank you very much indeed, David, and hello everybody. It's fantastic to see so many people on the call today. We had over 200 registrations for this webinar, which is a bit of a record for us. So we're absolutely delighted. Clearly, we're talking about the kind of things that people are interested in, which is really good. And this webinar is in fact the first in a series of 6 webinars that will be running this year around the issue of men cancer and HPV. And we'll share details of the next webinar, which is in July, at the end of today's event. So NOMAN and Global Action on Men's Health are working together in partnership to make the case for expanding HPV vaccination programs to include young men and boys throughout the world. And we have seen a big shift, in fact, in the introduction of gender-neutral vaccination programs in many of the high-income countries, but progress has been much slower in low and middle-income settings. So that's really where the challenge is now on this issue. If we're going to get gender-neutral vaccination on a worldwide basis, we need to see a much faster shift in the introduction of those programs in the lower and middle income countries. We launched a new initiative on this at the World Cancer Congress in September last year. We're very keen to work with as many individuals and organizations who support our goals as possible. And as I said, this is the first webinar in our program of work. So this is, if you want to find out more information about what we're doing together on this issue, please have a look at our dedicated website. That's a shot from the home page. So if you go to endhpvglobal.org, you can find out more. And in particular, you can see our policy document, our call to action report, which sets out the case for global gender neutral vaccination. Next slide, please. These are some of the organizations who are already have already endorsed our call to action. I'm sure you'll recognize many of them. And in fact, that's not the complete list. We have now over 50, I think it's 55 at the latest count, organizations who have declared their support. So it's not just us at Global Action and NOMAN who are calling for this. There's a wide range of support particularly amongst the cancer, HPV communities, and also amongst men's health organizations around the world. So our key messages, what the key messages are in our call to action are that we can protect everyone, males and females, from high-risk HPV infection. That's the HPV types that cause cancer, through gender-neutral vaccination. And to do that, we need a more ambitious, ethical, and equitable approach if we're going to achieve that. We think that global public health organizations should, and we're particularly thinking about the World Health Organization here, they should prioritize the elimination of all the cancers caused by HPV and consider all young people as a primary target for vaccination. At the moment, the focus, for perfectly understandable reasons, is on cervical cancer, but we have an opportunity not just to tackle cervical cancer, but the range of cancers, the wide range of cancers, and of course the other diseases caused by HPV. These cancers and other diseases affect both men and women. So we're calling for global gender-neutral HPV vaccination, which includes both boys and girls, by 2030, and very importantly, with a 90% uptake goal for everyone. Next slide, please. And you can see here that we're a long way off achieving that 90% coverage. This is the latest data that we have. It was published in the Lancet, a paper in the Lancet a week or so ago. And it shows, if you look at the global picture, that just 27% of girls have received one dose of HPV vaccine, and only 77% of boys. So the 90% target is far from being achieved for girls, and it's even the rate for boys is clearly currently much, much lower. Next slide, please. So that figure, the figures I just showed you, the 27 and 7% figures, apply to the global picture. If you look just at the countries which have vaccination programs, gender-neutral programs, which is about 70 at the moment, the rate, if you compare the rate for boys and girls, it's a bit closer. It's not such a big difference as 7 and 27%, but there's still, in most countries that have gender-neutral programs, the rate for boys is significantly below the rate for girls. We think that a higher vaccination rate in boys will protect more men and more women against the cancers and other diseases caused by HPV. And we think that there's also evidence, and we can see this in Cameroon and elsewhere, that introducing a vaccination for boys, in fact, also brings about a higher rate in girls by reducing stigma, which is attached to the vaccine in many countries. Higher vaccination rates throughout the population, boys and girls, make vaccination programs more resilient. In other words, if there's a crisis because of concerns about vaccine safety, unfounded concerns, I should say, about vaccine safety, or there's a pandemic or conflict, if a higher proportion of the population is vaccinated, that makes those programs more resilient. And of course, higher rates throughout the population creates herd protection. And finally, equally high rates in boys and girls demonstrate that responsibility for both individual and public health is equitably shared. We don't think it should just be the responsibility of girls to take on the burden of preventing HPV cancers and take on the responsibility for better sexual health. This should be something that is shared between boys and girls equally. So what we're going to do in this webinar is explore the barriers currently limiting boys' vaccination uptake and how they can be effectively overcome so we can achieve that 90% target for everyone. Next slide. And finally, before we move on to our main speakers, I want to acknowledge the support that Global Action has received for its work on men, cancer and HPV. We have an unrestricted educational grant from MSD, and our work is also supported by our colleagues at NOMAN is an Island. So I'll stop there. Thank you very much, and back to you, David.
Thank you, Peter. Well, ladies and gentlemen, without further ado, I'd like to introduce our first speaker, Maria Grandahl from Uppsala University. Maria, I hand over to you for your presentation. Take it away.
Thank you so much, and I'll try to get it into presentation mode. There we go. Thank you so much for the invitation and the possibility to talk about barriers to HPV vaccination for boys. So I just want to briefly mention the Swedish context. So we have a school-based, free of charge, gender-neutral vaccination since 2020, and parents have to consent. We also offer second chances to children up to 18 years of age. And the goal is, of course, the international and global uptake of 90% in order to eliminate cervical cancer. And in Sweden, school nurses are responsible for all aspects of the vaccinations. So moving on to barriers to HPV vaccination in general, what we know from the literature and previous published articles and studies is the low knowledge about HPV and the virus, and also low perceived risk for getting an infection. And of course, fear of side effects are very common, and to not have trust in the vaccine effectiveness or mistrust in governmental recommendations to vaccinate. And also we see misconceptions and fake news. And we also know that there are cultural aspects that have an effect on vaccine uptake. And of course, the most vulnerable with a low socioeconomic status are less likely to be vaccinated. And also individual attitudes and beliefs about the vaccine and the effectiveness can have an impact. And I also want to add emotional aspects. That's a significant factor. So barriers specifically for boys and young men then, also lack of knowledge, and I would say a very, very low awareness. Why should boys be vaccinated? And vaccine hesitancy in general, and lack of recommendations and or lack of discussions with healthcare providers about the vaccine, such as during a checkup at the GPs. And it's costly to pay from your own pocket, and logistics, not having easy access to where you can vaccinate. And this is the same for boys and girls. The idea that HPV vaccination may promote promiscuity. So vaccine hesitancy in 2019, it was pointed out as a threat against global public health. And it's mainly found among subgroups in the population. However, national vaccination programs, well functioning, can be significantly negatively affected, such as in Japan 2013 and Denmark 2015. Both countries had significant setbacks in the vaccination, and Denmark recovered after just a few years, but Japan, they had really struggled with HPV vaccination. But still now it's recommended to vaccinate again, so that's good. And so we have done some studies in this subject during the years, and this is some of the data results found among boys and young men's beliefs about HPV vaccination. We have done some qualitative studies, and Ida Enskär did interview studies with the younger children, age 11, and I did with the upper secondary class students, boys 18 years of age. So boys and young men are in general in favor of vaccinating. They believe it's important to promote equal health. It's a matter of equity. They think it's important to stop the transmission of the virus and to prevent cancer. However, they do have very low knowledge and awareness. Again, why should boys be vaccinated? And fear of needles, especially among the younger children. And the younger children also want to feel safe and well prepared for the vaccination, and they want to be informed by someone they trust, such as the school nurse. So here are two quotes. First, from an 11-year-old boy. "But guys, we can't get cervical cancer. We don't have a uterus." The older boy, "Well, since I don't know so much, I think I would decline. If I had more knowledge, then I would have some more freedom of choice." And Ida Enskär, a PhD student, is currently writing a manuscript about sociodemographic differences in HPV vaccination status among Swedish boys. It's a population-based registered study. Almost 200,000 boys are included, and it's the first 3 cohorts born in 2009 to 2011 who were included in the gender-neutral vaccination program in 2020. And what we can see is there are associations between not being vaccinated and to have a migrant background, at least one parent born abroad, and families with lower level of income and also lower parental educational level. So there are significant differences also in a high economic country such as Sweden. And this study is a collaboration with Public Health Agency of Sweden, Karolinska Institute, and Uppsala University. Most important, what can we do about the barriers? Well, we should include boys in national vaccination programs free of charge. We should have easy access to the vaccination, such as school-based vaccinations. We should offer second chances and catch-up vaccinations. Since there are a lack of education and knowledge about the vaccine and the virus, we should definitely have more information to boys and parents why it's relevant for them to be vaccinated. We need to address concerns, rumors, and misconceptions. And we know that healthcare providers have a key role in information and communicating about misconceptions, etc. So it's important that they have good knowledge about the virus and the vaccine, so they have self-efficacy to communicate and be brave and kind in the communication. I think it's very important to be transparent. We should collaborate top-down, bottom-up. And what we have seen in our studies for years is that school nurses and healthcare providers want national guidelines to support them, especially in how to address families that have declined the vaccine. So, leave no child behind. I would like to end with this quote, if I can see it. Just have to change my, yes. So, the main reasons for vaccinating boys, it would definitely be to stop the virus from spreading. That's because everybody is helped if it would go away. Cancer is terrible if it should happen to anyone, regardless of it being a man or a woman. And if you eradicate all forms of it, the faster the better. I'm for it. So that's why I would like to consider taking the vaccine. A young man, 18 years of age. And I want to thank all my co-researchers, and here you see a lot of references. So thank you so much.
Thank you very much, Maria, for a very thoughtful presentation on your work and the Swedish experience. Please do keep your questions coming in on the Q&A. As I said, we'll go to our next presenter, and then we'll invite Maria and Tashi on stage for the questions. So thank you so much, Maria. I'm now going to hand over to our second presenter, Tashi. If you can join us. That's great. Tashi, we can see your slides. Yeah, that's on the screen. I don't know if you want to go back to start. I don't know if you're able to share your camera. We'd love to see you as well. There you are, sir.
Okay.
Please begin.
Good morning, good afternoon, and good evening. So thank you very much for the organizers to giving us an opportunity. So I'm Tashi Dawa. I'm working with the Ministry of Health in the vaccine division. So today I will be sharing the experience on gender-neutral HPV vaccination program in Bhutan. So Bhutan is a very small country with little less than 800,000 population, with 20 districts, and we have very small cohort of reproductive health women. And our health system is three-tier health system. So we have 3 referral hospitals with 54 hospitals and 186 primary healthcare centers, which provide most of the activities are preventive and promotive activities, which includes the vaccination of all type of vaccines in the country. So in relation to HPV related cancers in Bhutan, so if you look at the crude incidence rate of the HPV vaccine related cancers in the 2023, HPV related fact sheets. So we have highest with the cervical cancer. I think it's no doubt that every country will have the similarity. Then and among in females, and also we have the oral cavity cancer is the second leading cause related to HPV. And for male, we do have the similarity with the oral cavity cancers, although the incidence are slight higher to men. And also we have laryngeal cancers for male as a second common most related to HPV. So in Bhutan, for the last 9 years, we had relatively having almost a constant detection of HPV cases, and the dates are also remain constant. For over the last 9 years, we had around on an average 60 new cases detected annually with the death of 20 per year. So for the introduction of HPV vaccination in girls, so in 2010, under the patronage of Her Majesty the Royal Grandmother, Bhutan had initiated the HPV vaccine for girls, especially focusing on 13 years to 18 years as a campaign mode. This was possible because of the support of Merck Sharp and Dome and collaboration with the Australian Cancer Foundation. So we have a good coverage, so we'll discuss later on. And in the following year, in 2011, Bhutan had integrated this HPV vaccine into the routine vaccination schedule as a facility base with a 3-dose schedule. But however, we have to revert back to, in 2014, we have revert back to the school-based program. So why we have coming back to school program? So we'll discuss later during the when we discuss on the coverage part. So following that, in just after 10 years of introduction of HPV vaccine for girls, so we had introduced HPV vaccine for boys in 2011. So initially we had focused on 11 to 14 years as a campaign mode. So we have focused more on school-based and monastic institution as well during that time, because we have more than 95% of our children enrolled in schools and around 1% or 2% in monastic institutions, and that left us with only 2 to 3% out of reach. So that was the reason. In the following year, in 2001, our HPV vaccination for boys was also integrated into the routine immunization schedule. So we targeted our class 6 boys and girls we have vaccinated irrespective of their age in class 6. And for out of school boys and girls, we still provide as a facility based and institution based, especially for the monastic institution. So we focus on class 12 years of age for the out of school, whereas in class 6 we give vaccine HPV vaccine for both genders. So these are some of the pictures that we have taken during our HPV launch for the boys. So rationale why we have introduced HPV vaccine for boys. So in 2019, Bhutan tabled the global agenda on elimination of cervical cancer in the 144th sessions of executive board meeting of the World Health Assembly. So that derive us. So why we have tabled that agenda in 2019? So in Bhutan we had a lot of cervical cancers among the women. So especially when it comes when screening was done, but we could not reach to at all high level. And also when we diagnosed the cancer, the diagnosis was done at the advanced stage, and the treatment and it's very costly, and it was also difficult for the government to manage the treatment, and sometimes we had to send abroad for the treatment by the public from the government side. So that were some of the reasons that we have introduced. And also following that, we had developed the cancer control strategy for 2019 to 2025, where one of the key component was to introduce HPV vaccines for boys as well. That is one reason. And another reason was high level of community acceptance. So anything that we introduce in the country, because our community, they have good trust on our government and the healthcare providers. So that must be the reason that we have introduced. And nonetheless, in 2020, WHO launched a global strategy to accelerate elimination of public health, accelerate the elimination of cervical cancer for the public health by 2020-30. So in In conjunction with that, Bhutan's goal to achieve cervical cancer by 2030 with the 90-70-90 strategy. So these are some of the rationale that we have introduced HPV vaccines for boys. So if you look at this coverage, so we have a whole coverage from 2010 to 2024, and so for the girls, so you must be seeing that. So in 2010 we had a very high coverage, whereas in 2021, 2011, 2013 we have a low coverage. During the initial stage, so we have introduced as a campaign mode, then we started as a school base. And in the following year, in 2011, we have revert back as a to the health facility base. So during these 3 years, so our coverage for both first, second, and third dose was consistently low. Sometimes it is just above 50% coverage. So in 2014, we were to revert back our strategy to school base, and as I have already mentioned, that we have targeted class 6 girls and boys irrespective of their gender age. So that was the reason, that because as I have already mentioned, we have high school enrollment rate, and this achieved the high level of high coverage in HPV vaccination for girls, and similarly for boys as well. So starting from the initial stage, so we have started with school-based program, and we had consistently have more than 95% in above, both boys and girls. So we had some drop in 2022 during the pandemic time. So that is the only reason. Otherwise, we do not have defense coverage in both girls and boys. So we are achieving almost equally. So some of the strategies that we have adopted for the vaccination. So in the initial stage, it was with the third dose schedule. Later in 2016, it was changed to 2-dose schedule, and now we have switched to single dose in 2025. Now, the most important thing, the strategy that we adopted was school-based vaccination program, targeting all class 6 boys and girls, irrespective of the age, and vaccination of out of school girls and boys. We are targeting to 12 years, but still we are giving from 12 to 14 years through health facility wise. Then also we have an outreach clinic, and even we are going for the monastic institution where we have more cohort of clients for that category. And also we have strong advocacy and community engagement to promote the acceptance of vaccination, and close collaboration with the Ministry of Education for coordinated delivery, which is one of the key stakeholders, where in the education system we involve the health in charges of all the schools, so which help us to achieve high coverage. Then collaboration with the, and also we have integrated system of HPV was integrated with the Bhutan vaccine system. We have an online system where we can punch, where we can get report, and also we can reflect our if there is any EFI, then self-reporting systems are there. We can track and monitor in a real-time basis. So these were some of the strategies. And enabling factors for HPV vaccination. So how do we achieve this high level of coverage? So most important thing is strong leadership and political commitment, and also vaccination strategies. So like we focus, we have taken as a school-based strategy. So that is one of the major factor, and then availability of funding and support from the ACCF and the MSD, which is very crucial. Till now, we are getting HPV for boys from the MSD. So we would like to thank the MSD if there is any participants out here. And integration, EPA programs are integrated long time ago, since its inception in 1979. So this is one of the major factors that we could introduce without any resistance. And skilled vaccinators and workforce capacity. So most of our health assistants, we do not have a vaccinator. Our health assistants are giving the vaccination, so they have all full capacity. And also we have good adequate cold chain and logistic and supply management system established in the country. So this is also one of the enabling factor. And most important thing is community engagement and advocacy, especially at the local level, especially at the local government level. We need to have very strong community engagement so that we can have a successful program. So with that, the current status of cervical cancer elimination goals in Bhutan. So as per our target, we are to achieve 90, 70, 90 by 2030. But in Bhutan, we have already achieved it. HPV vaccination coverage for both boys and girls is above 90%. Screening for 30 to 65 years women are more than 90% and above. And those who found abnormal cells after the screenings are put on to treatment are also have 90% above. And with that, in 8 October 2024, Bhutan was awarded the interim certificate of achieving towards the elimination of cervical cancer as a public health problem by the Southeast Asia region WHO country office general director in the country, as shown in the presentation. So some of the key challenges. So if we list, there will be a lot of challenges. We do know that. So most important thing is ensuring the sustainability of funding in the long term. Especially, if we are going to give for the both boys and girls, we should not deprive the girls. So these are some of the challenges that we have. And procurement of HPV vaccine for boys at the GAVI access price is difficult. Although WHO recommend to give HPV vaccine for the boys, but there is nowhere stated that we can get at a GAVI access price. So this is some of the challenges that we are really facing. That's why still we are depending on MSD for the boys for the HPV vaccine. Whereas for the girls, we are supporting ourselves through the Bhutan Health Trust Fund. It's a non-governmental organization established by the government in 2002. So this is the where we can get all vaccines and essential medicines should be supplied through that. So we are getting about that. And HPV vaccination for boys was introduced during the pandemic. And so we had some challenges and issues with closures of school, frequent lockdown, difficulty in monitoring and delay in reporting system. There were some issues, but now we do not have much. And although, no, if you anything that we add on the system, the burden, additional work on the health worker is extra, and that too it becomes sometimes bothersome, but still our health workers are carrying out it diligently. So in conclusion and lesson learned, so what I would suggest is strong leadership and high level of political commitments are very crucial and very important to success for any new program implementation. And school-based vaccination is an effective strategy for in our country, because we have more than 95% of school enrollment, primary enrollment. That may be the reason. And multi-sectoral collaboration, including the development partners and other stakeholders, is very important. For the first time, we do not have money, finance, we do not have capacity. We need to depend on the development partners and other stakeholders. So this is most important. And although in Bhutan we do not have any vaccine hesitancy, but still continues to have advocacy and risk communication plan to mitigate to have promote the demand and uptake of vaccination is very important. Then, as I have already highlighted, that community engagement, ensuring local ownership and acceptance is very important, and securing sustainable financial support is vital for long-term implementation of the program. I think with this I have end my presentation, and thank you very much. If there is any question, let us know. Thank you.
Thank you very much, Tashi, and thank you, Maria, for your wonderful presentation as well. Ladies and gentlemen, this is now when we will open up the floor to the Q&A session. We have about 20 minutes or so now, so please do submit any questions into the Q&A. I'll be going through these now. Ian, to your point about the International Council of Nurses, absolutely, that's someone that we will be picking up conversations with. I think Peter has started about 54 organisations we're working with now, but absolutely someone that we should be picking up with. A question for you, Maria. Could you remind us what the national recommendation on HPV vaccination is from the Ministry of Health in Sweden? Are boys included, equally included, excluded, or deprioritised? Could you maybe give some clarity on the framing of the recommendation from the Swedish Ministry of Health?
Thank you. Yes, so from autumn 2020, we have a gender-neutral vaccination program for children aged 10 to 12 years of age. That in general in 5th grade. So no it doesn't matter which sex, everyone are offered the vaccination. And we do have high coverage. However, it's less than the other childhood vaccinations. So we still think that's important to maintain a resilient vaccination program, because we know that it can be negatively affected quite soon due to, media misconception and everything. Yeah.
Thank you, Maria.
And also, boys can be vaccinated up to 18 years of age in school, but we don't catch up vaccinations for the older boys yet.
Yeah. Because I'm right in saying in Sweden for girls there is the catch-up program in place for older than 18. Is that correct?
Yeah, it depends on the specific region. We have 21 regions, and they are in charge of all healthcare. But we do have, it will end now in the end of June, elimination of cervical cancer program, including girls up to 26 years of age. So they are offered the 9-valent vaccine as a catch-up.
Thank you. Tashi, a question for you. Could you perhaps share, in Bhutan, how are men themselves engaged in the community engagement efforts and advocacy around HPV? We often find men left out of these conversations, and it can make acceptance, access, and uptake more difficult. I think from looking at those very impressive coverage rates you shared with us, Bhutan have been very successful there. I wonder if you could share what you believe some of the key ingredients have been there for that success.
Okay, thank you for the question. So in Bhutan, we have layers of strategies how we can engage the community, including men and the young boys and girls. So in Bhutan, at the national level, programs are carried out, and at the district level, our district public health officers are engaging through the district development meeting. So there we encourage our men to speak up. And at the school level, so we have school coordinators where they can encourage the participation of male. And in Bhutan, in most of the cases, we have more male than female in the civil servant and educated lot for now, but in future it may change. And also in the community, we have a village health worker, volunteer health workers at the community. So where we have more than 80% of the VHWs are men. So through that way, we have engaged most of the men that to involve in the communication and provide awareness program on the importance of HPV vaccination for boys. And also we have particularly informed our young boys that so you are the carrier and your sister will suffer. So these are the message that if you stop transmitting the virus to female, then you will have our mothers or sisters will have cervical cancer. So those are some of the message that we have tried to provide it. And in second, if I answer to the second, is there a reason for decreasing? So in 2020-22, so we have some decrease in both male and boys and girls for the second dose, because it is basically due to the frequent lockdown. So that was in the pandemic period and frequent lockdown. So we could not reach to all the clients who have taken first dose, and during the second dose there was lockdown. Most of the schools were closed, and so we could not achieve that high. But it is not the reason that because of low coverage we have shifted from 2 dose to single dose. It is based on the effectiveness, whether we have deliberately look at the other countries' research and all, and it shows that 2 dose and single dose effectiveness is almost similar. So there is no difference. So it is just the wastage of time and resources. So that's why we have shifted to single dose. It's not that because of low coverage we have shifted to single dose. Thank you.
Thank you, Tashi. And I think that's answered someone else's question about the move to that Bhutan has made to 1 dose. Maria, if I can perhaps throw to you, I'm struck by one of Tashi's comments there, because I think this speaks to something that you were mentioning during your presentation. if you stop transmitting the virus to girls, that protects them from cervical cancer. And I think that speaks to one of the core reasons as to why we should be protecting males. Could you perhaps share, is that the framing of how the framing of the language of why boys should be protected in Sweden? Is that one of the core messages? Is it talking about all HPV cancers? Perhaps could you share some information as to the sort of framing of the program?
Yes, so thank you. The information to parents and children have developed during the years. We started with HPV vaccination for girls in 2012, so we were quite late actually to be a high-income country due to a lot of things that happened. But firstly, the communication was only it protects against cervical cancer. But now we try to be more transparent in communicating why boys also should be included, since they also can be affected. And on herd immunity, a group level, you can be prevented as a boy, but not as a single boy. And we travel a lot. It's a global world. So even if HPV is hereditated in one area, it's not in another. And we see, for example, now we are in the northern Europe, in Scandinavia, and just across the sea we have the Baltic countries with they don't have that good vaccination programs, and they have very high level of cervical cancer. So even in quite the same geographical area, there are very differences. So that's why I think it's very, very important in an equity aspect and for the individual boy to be vaccinated for herd immunity for everyone.
And could I just say, going to your presentation, you were talking about boys and young men's beliefs and attitude. Could you share any information around parents' attitudes to vaccinating young boys in Sweden? Is this a problem, and how have you seen that successfully overcome?
Well, since we do have high coverage for boys, it's over 80%, but still the knowledge is very, very low among parents regarding why boys should be vaccinated. But in Sweden, we in general have a trust in governmental recommendations and in the school nurse and the school health. So when parents are offered a vaccine, they just consent. Maybe they don't even know what it is, but they consent. So the difficult things are some of the with high education level, they decline vaccines, and also the very low. So it's different. So we have these vulnerable groups that Ida is currently writing the manuscript about, the population-based, register-based studies, that we see differences in socio-demographic for the uptake. So I also think it's very important to maintain a resilient program. And we have to be proactive. We can't sit back and believe that now everything is okay, because the world is vulnerable, and we all see changes from day to day. So we have to be proactive, I think, and communicate.
Maria, I agree with that. And I noted in your slide you were saying around, we know that vaccine hesitancy is one of the greatest threats to public health. And the HPV vaccine isn't in a silo. This is something that we're observing across other vaccines as well. I've got a question here from Fabrice, which I'd like to pose to both of you. Does the framing of these policies around cervical cancer instead of HPV-related cancers limit reach? Does that provide a limit to reach and vaccinate boys, as it then this issue is then framed as a cancer that only affects women? So I think, if we talk about this issue purely in terms of cervical cancer, does that then limit the engagement and reach and conversations we can have around this issue with the whole population? So Maria, I don't know if you want to come in first, and then Tashi, I'd love to get your thoughts on that.
Yes, definitely. And regarding parents' beliefs and views, the there are a lot of misconceptions. Some parents believe that, the girl might have infertility if she vaccinates, she's too young, she will have earlier sexual debut, higher sexual risk-taking, and actually we have seen the opposite in our studies. So I think it's very important to have transparent information to the population. And I also believe that we should not only talk about cervical cancer because it's HPV-related cancer, and we also know that the virus, you can be affected in one area in your body, but the virus transmits. So I think it's very, very important, and these are quite new findings. So HPV-related research, I always think that, okay, now we know everything, but we don't. So then something happened globally or in the society. So I've spent over 50 years with this research, and still we have things we have to do more studies about. We don't know everything.
Yeah. And Tashi, I'd love to hear your thoughts on that question. Oh, Tashi, you're on mute.
Sorry. So in Bhutanese context, so I think even if we have a very good framework and strategies, so it is very difficult for everybody to get engaged and cover. So in our case, we do see a lot of cervical cancer cases, but also when we really going to focus on cervical cancer, we tend to forget with other cancers like penile cancers, vaginal cancers, then oropharyngeal cancers, then oral cavity cancers, and everything is linked together. So in Bhutan, even the head and neck cancer in Bhutan, we do have most common head and neck cancer as well, and so we have few information. So we have a cancer registry, and the report will coming out very soon. So that's why I think we need to focus more on gender neutral advocacy and passage of message saying that okay, cervical cancer is only for females, so we usually tend to say like that. So instead of that, we can say that HPV can cause not only cervical cancer, but these are the diseases that HPV virus can cause the diseases, and these diseases are not limited to female. And if you look at our in Bhutan's data, so we have oral cavity cancer more than female. We have 1.6, whereas we have 3.6 around 3.7 incidence, whereas even the laryngeal cancers we have 2.5, and female they have 0.28. So we have to shift the ways and the key messages. I think that's how we are going to we are doing it, and we need to further elaborate on that. And still, although we have a high level of vaccine acceptance, for now we do not have any vaccine hesitancy, but we never know, it will come up. And so we are still under process of framing the social behavior strategies to uptake of vaccines. Still we are undergoing, and we have a long way to go, although we have a very good coverage, but we need to sustain it. So how to sustain it, we have to fight for that. Thank you.
Thank you both. And just a quick follow-up on that, and I think I get the impression from your answer. Do you think that everyone should receive the same information about HPV, or should we have more tailored strategies to communicate with boys and to communicate with girls around the cancers and diseases that are caused by the virus, or should we be educating everyone together? I'd love to hear if, any reflections or thoughts.
So in Bhutan case, we do not have separate key messages. So we are giving equal opportunity. So we are saying that if we are going in the then if we are saying that this is for the boys, this is for the girls, then we are taking bias. So there is no equitable or no. Then maybe the information may be biased. So we are giving as a parallel. We do not have separate documents or material for girls and boys. So we are using the same.
Thank you, Tashi. I don't know, Maria, if you wanted to come in on that. There is a question for you, actually. In post-pandemic period in Sweden, has there been any effects towards vaccine skepticism that affected HPV vaccinations? And if so, how have they been dealt with by health authorities?
Thank you for that question. Well, Sweden, we were one of the few countries worldwide we didn't have a lockdown, so the children were in school as usual, in general, at least the younger children. So the vaccination program were not that affected. But we know, from the late 1990s with the Andrew Wakefield fake news about MMR causing autism. And then we had the swine flu in 2009, 2010. And that really affected the Swedish population regarding vaccine. And then the COVID-19, of course, we had groups that didn't want to be vaccinated, especially migrant groups. And there were major cultural aspects. So that's why I think, like Tashi also said, we have to have sustainable programs and be aware of what can affect.
Yeah.
So we've done quite good. We've done quite good to answer the question. Yeah.
Well, and I think, as you said, it's we can never sit back and remaining proactive to the challenges that we said. Just actually a question for Tashi on the sustainability side from your presentation. You raised the point around sustainable financing for Bhutan's program, in that you've clearly it was 2011, I think it was, that you said that there was the initial program for girls, and that was then expanded out to boys. But one of the potential challenges for Bhutan was around funding and accessing the vaccine at the Gavi access price for boys, which I understand under those frameworks isn't possible for countries. In Bhutan's case, from your presentation, I understand it that you've identified that protecting males is vitally important for your cervical cancer elimination strategy. So I don't know if you can sort of share any insights or thoughts as to what the future looks like for Bhutan.
Thank you very much. So Bhutan being a very, just above the least developed country, and our economy is very small and it is very fragile. So it is always concerned not only to this vaccine but any program related to health, because the return on our health is negligible or not seen by our politicians or our leaders. So that is a big challenges. And somehow we have initiated, I have already informed, we have a trust fund called Bhutan Health Trust Fund, which was initiated long time ago in 2002, I think. And this we have like crowdfunding type, so we have a good amount of fund. So their mandate is to provide, number one, provide free vaccination to the public and other essential medicines. So we are expecting that in case if our development partners and donors are withdraw, then we have to clinch on that. But at the same time, we will have to forego some of the essential medicines which are provided free of cost to the general public. So in that way, we can say that somehow we are stable with the financing. But most important thing is, if we are getting through Gavi access price through UNICEF, then it would be much more appreciated, because WHO is trying to encourage all the countries to have gender neutral vaccination in one way, and in other way they have not given us the opportunity to get that vaccine through the Gavi access price. So although we need very small amount of quantity of vaccine, but for a small country with a small economy, that is pinching us actually. And we are expecting that in few years other development partner will support us, and in the meantime we will try to transition. We have a transition plan how to take up that boys HPV vaccine by the what do we say now, Bhutan Health Trust Fund.
Thank you, Tashi. I think that's very interesting, that point you raised. On the one hand, in terms of global health authorities wanting to encourage everyone to get protected, but then we have this issue which isn't unique to Bhutan in terms of accessing financing for all that is prevented in some respects by the current finance framing and mechanisms. So I think that's a conversation going forward. How do we create smart and suitable policies for countries to support them so that they can protect their populations? We have just a couple of minutes left, so I'm afraid that we're going to have to draw the Q&A to a close. Tashi and Maria, thank you so much for your thoughts and insights. They're greatly appreciated. And if people do have questions for us, please do send them through so that we can try and answer those for you. If we can go to a little bit more about our work. So Global Action on Men's Health and NOMAN's forthcoming activities that coming up. If we can get the next slide. So please do sign up for our new quarterly newsletter, Men, Cancer and HPV News. It's been shared in the chat. It's available to access on the website as well for information about our activities and other information around the news related to those issues. Next slide. Our next webinar, you don't have very long to wait. It's going to be on the 8th of July, and that's going to be focusing on HPV lived experience. We're going to be joined by Patrick and Jason, who are penile and throat cancer survivors, respectively. We're hoping to have some other speakers as part of that, sharing those experiences. And we know those lived experiences are incredibly powerful tools of courage and of advocacy and of need, why we have this need for action in order to prevent HPV cancers. The registration link will be available soon, so please do make a note in your diary, and we hope to see you there for that. In terms of our other activities in 2025, we're going to be forming an international expert advisory group to assist us in writing a joint statement on the need to scale up the protection of both boys and girls in HPV, particularly in low and middle income countries. We're looking to publish that in a high impact journal and then share with over 100 global experts to seek their endorsement. So if you are interested in being part of that, supporting us with that, please do get in touch with us and let us know. At IPVS in Bangkok, we will be establishing an Asian network to support advocacy practitioners, research and policymakers, and expanding a focus on the protection of boys as well as girls in that region. We've heard that wonderful case study from Bhutan. We'd like to support more countries in those effects and hear more from advocates within countries in the region. So if you are going to be at IPVS in Bangkok, please do get in touch. You can endorse our global call to action report, which Peter mentioned at the start. The report will be shared in the next slide. It's available on the website. So if you are part of an organization, please do get in touch with us either on the website or via Tim's email, which he's shared. As we mentioned, we are advocating for change to global policies and targets which restricts expansion of immunization programs to boys. We talked about one of those barriers there in terms of the need for policy exemptions for countries under existing guidelines. So if you want to be part of that, if you have more information you can share about that, please do get in touch. Likewise, building a coalition of governments who are undertaking this initiative or are seeking to. So please do get in touch. I've rattled through. We're about 1 minute past 10. Our case to action report is available for you there. This webinar has been recorded. It will be available on the Global Action on Men's Health website. We'll make it available on endhpvglobal.org. And I think that's our final slide. Thank you so much for being with us. Thank you, Maria. Thank you, Tashi, and thank you, Peter, for your presentations. And may I wish you all a very pleasant rest of your day. Thank you so much for joining us. Thank you. Goodbye.
Goodbye.
Thanks, everyone.